Hematological considerations. This is where the patient has anything that causes them to clot more readily or less readily. Here are our chapter objectives. We're going to be able to identify medical conditions associated with increased bleeding, define different types of bleeding disorders, determine whether treatment modifications are necessary for conditions with increased bleeding, identify medications that affect clotting, and describe the management of a hematological emergency in the dental hygiene service area. Differentiate between red blood cell disorders and white blood cell disorders. So bone marrow is responsible for the formation of blood platelets. Platelets are essential for homeostasis, and homeostasis is clotting of the blood. Blood platelets are also a natural source of growth factors. Fibrin coating helps platelets stick to walls of injured vessels and each other. And here's a figure showing when the body sustains an injury, a chemical reaction causes the platelets to become sticky and adhere to each other and the injured blood vessel, producing a fibrin coating which forms a mesh that stabilizes the clot and seals off the injured area. Uncontrollable bleeding is the first stage of a hematological emergency. If bleeding continues too long, the patient will become weak and eventually unconscious and eventually dead. How do we determine clotting times? Well, we need to know the complete blood count, how many red blood cells are there, how many thrombocytes are there, what's the white blood cell level like, the bleeding time, which is how long it takes for you to clot once you're cut. But the international normalized ratio is the most reliable test, and this is the normal is 1, but people that are on anticoagulants may be in the 3 to 4 range. Prothrombin time is also a way to measure, and partial thromboplastin time is another measure of clotting. One of the conditions that a patient can have is thrombocytopenia, and this is any condition where the blood platelet count is abnormally low, and a normal count is 150,000 to 400,000 cells per millimeter. If you have less than 50,000 cells per millimeter, you will have a spontaneous bleed. Some of the causes are decreases in production of thrombocytes or platelets due to cytotoxic drugs or bone marrow irradiation, or an increase in platelet destruction or consumption due to such things as autoimmune thrombocytopenic purpura, which is where our own immune system attacks our platelets. The capturing of circulating platelets in the spleen is due to an overactive spleen, pregnancy, or drug use. There are many drugs that have an effect on clotting and therefore thin the blood. One of these is aspirin, which has antiplatelet properties. And we do need to remember if we're doing a scaling and root planing or a full mouth debridement, we may have more bleeding in the patient taking high doses of aspirin. This will not occur so much in the patient taking child's aspirin or 81 milligrams of aspirin daily. Plavix is another drug that has antiplatelet properties. Again, we have to consider if we're digging around underneath those tissues, scaling, probing, anything that would disturb the tissues is going to cause more bleeding. There are other drugs that patients are on for their hearts. Warfarin or Coumadin is a common drug that is taken for patients who have had heart attacks or strokes, irregular heartbeat, prosthetic heart valves, or pulmonary embolism. And you cannot use other drugs with warfarin because they compete with the same enzyme for metabolism in the liver. This is aspirin, antidepressants, natural health products like CoQ10, ginseng, and vitamin K, and statins, which are used for lower cholesterol. And again, the considerations are the amount of bleeding. We may need to contact the physician to see if we need to discontinue this drug for a few days prior to a more bloody situation. And here are some of the normal factors. A bleeding time of 1 to 6 minutes is considered normal. However, this is not as reliable as the INR. The normalized INR ratio is 1, but less than 2. You may proceed with routine care. 2 to 3, but proceed, but do one area and see how well the patient's clotting until you move on. 3 to 4, you need to get a medical consult. Again, greater than 150,000 platelets per milliliter is normal. Less than 50,000 platelets per milliliter will cause spontaneous bleeding, so do not perform elective treatment. Hemoglobin in males is normally 13.6 to 17.2 grams per milliliter, 100 milliliters. Females is a little lower, 12 to 15 grams per 100 milliliters. Hematocrit is 39 to 49% in males normally, and 33 to 43% in females. Other blood thinning medications include antibiotics because these drugs have the ability to affect vitamin K production and can influence the production of prothrombin. These antibiotics could have an adverse effect if the patient is also taking warfarin. Statins reduce thrombin's ability to produce fibrin, which is a sticky stuff that makes platelets stick together. Herbal medications, many that start with the letter G, can intensify the thinning of the blood or of a patient taking warfarin. So you need to quiz your patient, are you taking any garlic, ginger, any other supplemental herbs that may affect your medication? Here's some other blood thinning drugs. Dipyridamole. This is used to reduce the risk of blood clots after heart valve replacement, and it works by inhibiting thrombus formation long-term and causes short-term vasodilation. Agranox is another that prevents transient ischemic disease. When combined with low-dose aspirin and extended release dipyridamole, the platelets become less sticky and thus less able to form a clot. Pradaxa prevents strokes and blood clots in patients with atrial fibrillation. Again, this works by inhibiting thrombin formation. Plavix prevents blood clot formation that causes heart attacks or strokes. And this again inhibits platelet aggregation and thrombus formation. There is now a new drug that will reverse the actions of Plavix. It is called Andexxa. One of the bleeding disorders that can cause some problems with clotting is von Willebrand disease. This is the most common of the inherited bleeding disorders. Platelets aren't able to stick to tissue, reducing the body's ability to clot, and this is because of the decrease in the glycoprotein that's needed for the platelets to stick together. Symptoms can be petechiae, GI bleeds, epistaxis, which is spontaneous nosebleeds, You need to find out what the patient's blood platelet levels are and consult with the physician about what else might need to be done. Another disorder of the white blood cell system is hemophilia. And notice that hemophilia on this slide is misspelled. That should be a I in the philia, not an E. It's a group of inherited bleeding disorders in which the person suffers from the ability to form clotting factors. Hemophilia A, the patient is missing or has a deficiency in factor 8. This is called classic hemophilia. Hemophilia B is a lack of factor 9. This is called Christmas disease or Merry Christmas. You have hemophilia B. And you keep in mind for your patients, you want to consult your physician or the patient's physician before invasive procedures. Full mouth scaling is not recommended. You need to treat it in quads. Treat small wounds with regular first aid. And some patients may need to be in a controlled environment like a hospital, depending on how fragile they are. And for most dental hemophilia or clotting problems, we control the blood flow by pressure and applying gauze, and sometimes we can inject a little epinephrine right into the system in the area with our anesthetic carpules to constrict the blood vessels. Now let's talk about some red blood cell disorders. Iron deficiency anemia, this is where the body does not have enough iron, because iron is needed to make hemoglobin, and hemoglobin carries oxygen to the body's tissue. This is necessary for tissues and muscle to function effectively. Symptoms include fatigue, headaches, brittle nails, and sore tongue. Encourage the patient to seek medical advice, get a dietary analysis, and do some education. Work closely with the patient on home care strategies. B12 deficiency anemia is just as it sounds, a lack of B12 in the body needed to make red blood cells. Symptoms can be confusion, diarrhea, loss of appetite, shortness of breath. Causes could be abdominal surgery, celiac disease, Crohn's disease, or alcoholism. And remember that dietary analysis and education is priority. This patient may actually need to be treated with vitamin B12 injections. Okay, some of the other red blood cell disorders are pernicious anemia, which is the inability of the red blood cell to absorb vitamin B12. That means that vitamin B12 may be adequate in its levels, but the red blood cell is actually unable to absorb it. Symptoms will be weakness, fatigue, palpitations, and syncope or fainting. Oral manifestations are burning tongue, glossitis, painful swallowing, and again, we would manage this much like we would the patient with a B12 deficiency. Celiac sprue is the body's inability to properly metabolize gluten. And we probably all know patients that are sensitive to gluten. They need gluten-free products. Symptoms include nervousness, diarrhea, and extreme paresthesia. Dietary counseling is very important, but you may also see burning tongue syndrome, loss of papilla on the tongue, and ulcerated oral mucosa. Do not use mouthwashes with alcohol or prophy paste unless they specifically say they contain no gluten. Another red blood cell disorder is sickle cell anemia. This is where the red blood cell is actually sickle-shaped due to an abnormal form of hemoglobin that doesn't function as well. They're fragile and they break down easily in the bloodstream and cause anemia. Symptoms are joint pain, shortness of breath, nausea, facial and dental pain. We want to recommend close monitoring by their physicians and keep their appointments short. Don't tire them out. Aplastic anemia is where the bone marrow does not produce enough red blood cells, white blood cells, or platelets. And we treat this with blood transfusions, blood and marrow stem cell transplants. These patients are at a high risk of infections and should not undergo elective treatment. Polycythemia is the production of too many blood cells, and this leads to lots of clogging up of the vessel. Then we have white blood cell disorders, which include leukemia, which is actually cancer of the white blood cells in bone marrow and the circulating blood. This can have oral complications such as enlarged tonsils, enlarged lymph nodes, gingival hyperplasia or enlarged gingiva, progressive generalized gingival enlargement when oral hygiene is poor, so try to encourage the patient to have excellent dental hygiene. Loss of stippling appears pale red to deep purple in color in the gingiva. It bleeds easily, and ulcerations may occur as a result of infections due to the loss of white blood cells. Okay, Hodgkin's disease is another cancer of the white blood cell system. It's where there's uncontrolled growth or actual neoplasm of B lymphocytes that do not mature into plasma cells. This can have a variety of oral complications, oral mucositis, which is painful, infection. The patient is very susceptible to infection because of the decrease in white blood cells, xerostomia or salivary gland dysfunction, functional disabilities with swallowing, speaking, talking, eating, drinking, taste alterations where things don't taste as good as they used to or they taste much different. These patients are often compromised nutritionally because they do not have the desire to eat or the ability to eat. They can also have abnormal dental development. This can also happen in the bone when the patient is younger than 9. And we have neurotoxicity, which can often mimic dental pain. And of course, there will be bleeding because of the deficiency in platelets. And lumped under the hematological considerations are occupational exposure recommendations. Hepatitis B and C, we want to use complete personal protective equipment. Should be worn if the patient has had a history of B or C hepatitis. This means the liver has been compromised. OSHA highly recommends the vaccination against the virus be done for Hep B. We do this, it's 3 injections. Sometimes you have to get a booster. I had to get a booster sometime after my initial injection. There's no vaccine for hepatitis C at this time, so again we use universal precautions. Hepatitis D is immunity through the hepatitis B vaccine. It cures immunity to hepatitis D. So often if the patient has had hepatitis B, they will be okay with hepatitis D. But D is usually the result of drug use. We have non-A, B, C, D, and E, and hepatitis TT, which is transfusion related. Dental hygiene considerations. Again, we use the same precautions with all patients as we do those with hepatitis. So, as I said earlier, HIV is the disease that made us start doing what we all should have been doing in the first place, and that's wearing PPE. All individuals have the right to seek treatment for their dental needs. It is the responsibility of the dental team to determine how best to manage any individual who presents with health considerations. The dental team collaborates with other healthcare practitioners to offer the best possible outcome. Understanding how the body's clotting mechanism works, what various lab values might indicate, their potential complications, and how to manage complications will ensure proper care or reduce the risk of an emergency. When treating patients with hematological conditions, the dental hygienist or dentist considers what the patient needs to do before the appointment, what the patient needs to do, treatment considerations before the appointment, whether the hygienist can identify warning signs that would affect management of the dental hygiene appointment, and what the protocols are for handling an emergency with a patient who has a hematological condition.